morning, good afternoon, and good evening, everyone. Thank you so much for joining in our second episode of the webinar series. Today, we'll be discussing health and environment trade-off, a discrete choice experiment study from our colleagues from York. Some housekeeping notes before we begin. This webinar will be recorded and shared on our YouTube channel and shared with the participants after it's available. Second, please stay muted to avoid disrupting the speakers. You may use the Q&A function in the Zoom if you would like to send us your questions. And you may also raise a hand using the hand raise button in the Zoom if you would like to speak directly with the speakers in the Q&A session. Today's agenda is first, the speakers will present their discrete choice experiment study, followed by Q&A session, and then a brief summary and closing from us. So very briefly, participants, thank you so much. 115 registrants for this webinar. Some of you are already here, some of you may join later. For those who are not able to join, we'll get the recording as mentioned earlier. We have participants from over 25 countries, which is a great job. So really excited. So before we begin, we would like to introduce you the speakers for our webinar, starting with Professor Matthew Taylor. He is the Director of York Health Economics Consortium, YHEC, in the University of York. He has led over 100 economic evaluations for NICE in the UK, which is a central HT agency in the UK. He has also served as a committee member in NICE in the past. Second, we would like to welcome Melissa Pegg. She is a senior research consultant also at YHEC, University of York. Besides her affiliation at York, she is co-chairing a HTAI working group called Environmental Sustainability in Health Technology Assessment. And she has really been pioneering how we can include environmental sustainability in health technology assessment. So really, it's our pleasure to invite these two incredible speakers and share your study with us. So without further ado, Mel and Matthew, over to you.
Thank you very much, Saren. Oh, it's just incredible to have this opportunity to present to all of you today. So thank you very much indeed. I'm just going to share my slides. Can you see those all right, Saren?
Not yet.
Not yet.
Not yet. Let me check again. Screen 2. Let me see. It's only showing screen 1. Let's see what's going on. Screen 2, share. There we go. Hopefully this should be it now.
Yep.
Okay.
Great.
Perfect.
Great. Thank you so much. Oh, thank you again for the opportunity to present for you, Saren, and everyone at HITAP and everyone who's online at the moment and listening back to the recording. So I'm going to take you through a very brief snapshot now of the planetary boundaries. So these are tipping points that regulate the stability and resilience of the Earth systems. The reason for talking about this very briefly now is to talk a little bit about climate change. I know there were some questions about what is climate change, how does it impact us? And this is an important consideration to first provide some background information before we go into the DCE itself. So anthropogenic effects, so human-induced effects on climate change, are one of the greatest health threats. So here's a schematic diagram of the latest study of the planetary vital boundaries. So there's 9 of them, and we've transgressed 6 of them now. So this particular model, so the model was, this is the 3rd edition, the 3rd major assessment of the planetary boundaries framework, first introduced in 2009. So this latest model provides a complete checkup of all 9 processes and systems that maintain the stability and resilience of our planet. So while transgressing a boundary is not equivalent to necessarily drastic changes happening overnight, together they mark a critical threshold for increasing risk to people and the ecosystems that we're part of. So from global warming to the biosphere and deforestation, for example, the critical current risk of novel entities, so you can see the so-called worst offender, includes things like microplastics, chemicals, pharmaceuticals, and then as another example, we are experiencing significant depletion of freshwater systems as well. So the impact of climate change on human health is also widely accepted. For example, air pollution has overtaken high blood pressure and smoking as the leading contributor to global disease, equating to approximately 12% of deaths globally, with about 400,000 excess deaths in the UK. As an example, and approximately 2.5 million cases of non-communicable diseases, including coronary heart disease and diabetes cases attributable to air pollution, costing a significant environmental cost. So it predicted that nitrous oxide and particulate matter 2.5 will significantly increase by 2035 if we don't address climate change. And toxic pollutants, including plastics generated by United States, as an example, the United States healthcare industry led to a loss of 614,000 disability-adjusted life years. So here's a Statista report from 2024. 60,000 respondents across 63 countries shows climate change is viewed by them as a major concern globally, with around 90% of respondents to a 2023 survey viewing it as a serious threat to humanity. So in the UK, the percentage was 83%, ranking towards the bottom, and it was 77% in the US. Overall, the report shows there's rising emissions despite growing awareness. So the healthcare industry itself contributes to environmental damage, accounting for approximately 4.4% of the total greenhouse gas emissions globally. Without action, global healthcare emissions are projected to be more than tripling by 2050 to 6 gigatons a year, increasing average global temperatures by up to 5.7 degrees Celsius if we collectively continue along the same trajectory of greenhouse gas emissions. Rapid reductions in greenhouse gas emissions may stop or slow this increase in global temperature, and the healthcare industry is contributing to this increase. So the evidence to support the broader environmental harm of health technologies is growing. We have global leaders, healthcare professionals that are surgeons and anaesthetic consultants that are producing peer-reviewed publications now and have been for the past 10 years to illustrate the environmental impact, the broader environmental impact, not just carbon dioxide, so waste produced by healthcare, the use of single-use devices, for example, the effects on biodiversity, the effects on our air quality, the depletion of resources and water pollution, which are attributable to pharmaceuticals and medical devices, for example. So I'll pass over to Matt now, who's going to continue the presentation. Thanks, Matt.
Thanks, Mel. If you stop sharing, I can then bring my slides up, I think. There we go. So I'll talk briefly about why we wanted to do this research, and then I'll start to talk in a bit more detail about discrete choice experiments and why we use that method for answering our questions. So we started with the basic premise here that including environmental outcomes as a decision criteria in healthcare will likely mean that there will be some trade-offs to make. And by that, I mean that we might have a decision that's something like, should we use a different treatment because we think that it's going to be more better outcomes for the environment? So if we did do that, we might be trading off because this treatment might also increase health for the general population. It might be a better treatment for people anyway. So that means it's better for health and it's better for the environment. Or it might be an intervention that's less good for the direct health of the patients, but is better for the environment. So we've kind of got two criteria there. I'd argue that if it increases health, then we should have probably been doing that anyway. We should have been using that treatment in the first place. So the environmental criteria didn't really change the decision in that case. So actually, it's probably more likely this case here, where we've got an intervention that decreases health but improves environmental outcomes, that changes our decision here. And if that's the case, then we are going to be making some kind of trade-off, and we have to understand whether we're prepared to make that trade-off. The next point to say is when we're making decisions, it might not be about changing treatments as such, but it might be about changing how we manufacture or deliver or dispose of this intervention, whatever it is. Again, we might have two scenarios here. One is that that approach is cheaper. The other outcome is that it's more expensive than current healthcare. If the approach is cheaper than current healthcare and is better for the environment, then again, why weren't we doing it anyway? We should have been taking that approach anyway. If there's a better way of manufacturing a product or disposing of a product that's better for the environment and it's cheaper, we should just be doing that anyway, irrespective of whether it's better for the environment or not. On the other hand, if it's more expensive and we want to you still use that because it's better for the environment, then those increased costs mean that less money will be spent on other healthcare, and therefore, again, there will be some kind of trade-off. So we want to think about those trade-offs and whether we as a society are prepared to make them. A couple of examples that we might want to think about here are two choices of anaesthetic, where anaesthetic A may have a lower greenhouse gas effect than anaesthetic B, but evidence suggests that anaesthetic A may have worse outcomes for some patients. So we're trading off there. Do we choose A because it's better for the environment, but it's worse for patients? Or do we choose B, which is better for patients, but worse for the environment? There's a trade-off to make. Likewise, the other example is switching from drug A to drug B. It might save money because drug B is a generic drug, therefore increasing the budget for drug B overall. However, it might be that the ecotoxicity of drug B is greater, meaning that it might be more polluting to water systems, biodiversity, and potentially to humans as well. So again, we've got a trade-off to think about. Are we happy to go for the cheaper option, which is great because it will release budget for other healthcare spending, but it harms the environment? Or should we pay for the more expensive intervention that might harm the environment more? Again, trade-offs that we need to think about. So we wanted to know, what does the public think about this? And that ultimately gives us our objective for this study. We wanted to test, is it feasible to elicit opinions from, in this case, the UK public citizens around the trade-offs between human health and environmental outcomes? And as a secondary question, we also wondered whether the actual location of the environmental consequences made a difference to those preferences. So ultimately, we want to know, are there different outcomes that people are interested in here and different outcomes that people might prioritize over other outcomes? So we decided to do that using a discrete choice experiment. And I'll very briefly talk about what discrete choice experiments are, how we set them up, what the basic principles behind them are. So first of all, there are two different ways that scientists tend to measure preferences in general. The first way is to look at what we call revealed preferences. That means we just observe what people do in the real world. If we look at people getting into their car and putting seatbelts on, that tells us that people probably like being safe. That reveals their preferences to us. If we see people paying lots of money for high safety equipment for whatever they're doing, that shows that they have a preference for safety and they're willing to pay a certain amount of money for that. So that's very useful to look at, but there are lots of limitations to that because it won't always necessarily answer the exact question that we're doing. We can't control why they're doing those things. There might be other factors that affect these things for us. So another way that we often do it is ask people directly. We say, here's a questionnaire, or we interview them and we say, hypothetically, would you prefer this or would you prefer that? The benefits of that are that we can choose our questions exactly. We can rule out any other factors that might be influencing that decision. We can ask them why they made that decision. The downsides to that are that they're very hypothetical. It's not based on real behavior. It doesn't necessarily mean that that's what they will do in the end. But we decided in this case, the advantages of the stated a preference approach outweighed the disadvantages of it. So we wanted to go down that route. And there are lots of different methods that we could have used in that case. And we decided to go for the discrete choice experiment approach. And that's where I'll talk a bit about how that's used. There are lots of precedents of discrete choice experiments being used in healthcare. I don't need to go into all of these now, but just some examples of published studies where people have interviewed members of the public. They've asked them about their preferences about different healthcare interventions, different services in the healthcare system. There have even been some discrete choice experiments around sustainability issues. In this case, it's a very specific example, but they were looking at wine purchasing and the environmental impacts of wine purchasing and whether people preferred certain types of wine because they're better for the environment. So there are people that have done this kind of study before. We wanted to do it to look at specifically trading off your own health for better environmental outcomes. Now, conducting a discrete choice experiment generally has 4 major steps to it. We have to conceptualize the study, we design the experiment itself, we collect the data, and then we analyze the data at the end of it. So all discrete choice experiments would follow those 4 steps. There is a bit of terminology for us to cover here. Mainly, we're talking here about 2 things, attributes and levels. And an attribute is a characteristic or a feature of the policy, product or service that we're evaluating. And then for each attribute, we need to assign it a range of levels. And the levels are the kind of values that each attribute can take. And it must have at least 2 different levels in our study. Easier if I show you an example of that. So let's think of an example here where we're choosing between 2 meals. We want to choose which of these meals is best. And we're thinking about taste, the healthiness of that meal, how far we have to travel for that meal, what's the preparation time for the meal, and how much does that meal cost. Now, those things I've just described there are called the attributes. They're all the attributes of the meal, and these are the levels of those attributes. So you can see that one of the meals has very good taste, one of them has good taste. One of them might have had bad taste or very bad taste. They're the levels of those attributes. Hopefully that makes sense to you. Other terminologies to think about is every time we ask a question, we give them 2 alternatives. In this case, meal A is one of those alternatives. We always give them 2 alternatives. They choose between those 2 alternatives, and every time they do that, that's a choice task. We're giving every single person a choice task. And that's just important terminology to understand when we're talking about other things in this. When we choose how many questions to ask people, this can get very complicated. There are 2 different ways of choosing how to ask questions. We can go down the route of something called a full factorial design, which is where we ask them every single question possible with all the permutations, all the combinations of levels and attributes and everything compared against all the others. Or we can go down something called the fractional factorial design, which just looks at a subset of questions that we're asking each time. Now, just to give you an example of how that works. If we went down the full factorial design route, it gets very complicated very quickly. If, for example, we had 4 levels and 5 attributes in our study, that's the green line up here, that would mean we'd have to ask over 600 questions to each person. Now, nobody can answer 600 questions in a questionnaire. It's too burdensome. So we can't ask them everything. So in this particular case for us, we decided not to do that. We wanted to go down the fractional factorial design route. That meant we had to think about choosing a subset of these 600 or so questions that we could have asked. There are two ways to do that. We could have just randomly picked a subset, or we could systematically choose a subset. As you can imagine, if you choose them randomly, that can introduce biases. It can be inefficient to do that. Sometimes we'll be asking them two very, very similar questions, and we won't be giving them a good spread of different levels and different attributes and so forth. And therefore, we recommend that a systematic selection approach should always be used. If we do that systematic selection approach, there are 4 different things we need to think about. These are quite technical. I won't go into detail about this, but we have to think about orthogonality, the level balance, the overlap, and something called alternative dominance. I'll just very briefly talk about those. So orthogonality means that one attribute doesn't depend on another attribute in there. It's something in statistics we call correlation. We need to make sure that we're not asking the same question too many times in slightly different ways. The next property is about level balance, meaning that the number of times that each level in each attribute appears in the questions is roughly equal across all the questions that people answer. That minimizes the variance in all the parameter estimates that we get at the end of the study. It increases our certainty in the outcomes. I mentioned about overlap. Again, we want to make sure that we're not asking too many similar questions to people. It means that it's an inefficient design if we go down that route. If we ask too many similar questions, we need a nice spread of questions. And then finally, we need to think about something called alternative dominance. And that's when one of the questions we ask them to think about gives them a clearly better option than another. If in the meal example, we said all of the alternatives are exactly the same, except in one of them the meal tastes better than the other, we don't need to ask them that, because everybody would prefer the meal that tastes better if all the other attributes are exactly the same. So we want to get rid of all the questions that don't really tell us anything as well. So there are lots of ways that we can do that. You can do all of these things manually, or luckily for us, you can pretty much ask a computer to pick the subset based on all these criteria for us. We also need to think about how many questions we ask each person and how many people we ask. I won't go into detail on the statistics here, but there are 3 different ways that we could have chosen a sample size. There's a rule of thumb approach, there's something called the approximation approach, and there's an exact approach. All of them have different advantages and disadvantages. And if you look at discrete choice experiments being published, they will use different methods each time. In our study, I can't remember which method we used, but it told us that we needed something like 20 observations, and we ended up asking 500 people. So we were far above the minimum sample size anyway, so it didn't really matter which approach we used. Lastly, I just want to talk very briefly about designing the questionnaire. Questionnaires might include questions not just about the preferences for their people, but their baseline characteristics, what's their demographics, their age, their gender, their economic status, and so on. And that allows us to do extra analysis afterwards to see if there are different preferences for different groups of people in society. We provided people some background and context to the question. We asked them about their own interests around environment as well. We gave them some of the definitions, and we gave them some test questions as well, so that they could test out answering the questions. We should always make sure that the questions we include in the study before we get into the science of it have a purpose. Remember, it's quite burdensome for people to complete these questionnaires. They get bored when they're doing it, and you don't want somebody to be bored when they're answering the questionnaire. Otherwise, they start guessing at the answers. We want them to remain focused. Attributes of a good questionnaire. I think these things are fairly obvious, but the language in the questionnaire should be appropriate and clear. We should try to be engaging throughout the questionnaire by including interactions, good graphics, videos, sometimes where that might be useful. We try to avoid big blocks of text. Again, that's where people get very bored. Sometimes they don't read the text if we put lots and lots of text in there. And we try to incentivize all the patients to read the information by asking them a couple of questions about what they've read, just to check that they've read it properly and to make sure that they remember to read everything properly in case they get asked about it. And then finally, Collecting data from people, there are lots of different ways that we could do this. You could do it interviews, you could meet people in person and sit with them while they answer the questionnaire. You can do it over the telephone, or you can ask people to complete it themselves. That might be via normal mail, it might be done online, or people might all come into one big central location where they fill in the questionnaire individually. I think the most common approaches tend to be the online and the centralized location approaches for these questionnaires. Where possible, we should always collect response rates and completion times as well. It's very useful to know if somebody, say, completed the questionnaire online in 1 minute, that probably tells us that they were answering too quickly and weren't thinking about the questionnaire. If it took them 5 hours to complete it, that might raise some questions as well. 5 hours would be a long time to answer 15 or so questions. So collect the response times, the response rates, and collect the completion times, and that will allow you to validate whether you've got sensible answers or not. So that's my last slide, and I'll now pass back over to Mel to talk about our specific questionnaire.
Thanks a lot, Matt. Wonderful. Right, here we go. Can you see the slides all right?
Yes.
Fantastic. I was just saying to Sarah a moment ago that I'm now on 2 screens, so it's new to me. So thanks for your patience. So our publication was just a few months ago, eliciting trade-offs between population health and environmental outcomes, a pilot study. The objective of our study was to determine whether it is feasible to elicit opinions from United Kingdom public citizens around trade-offs between human health and environmental outcomes, and whether the location of the environmental consequences affects public preference. So a discrete choice experiment was developed to estimate the magnitude to which members of the public are willing to trade off different factors, including these attributes: human health, greenhouse gas emissions, extinction of species, and the location of the effects. So here are the attributes that I've just previously mentioned that are included in the survey and the various different levels. So for example, for the location of environmental impacts, that's either within the UK or overseas. And for endangered species, the choices were 100 species saved from extinction, no change, or 100 species lost to extinction. The study sample included 108 participants. These were members of the general UK population, recruited and implemented via Qualtrics, and the median completion time was 17 minutes. So utilising the attributes, this slide shows an example of 2 scenarios provided to the participants to choose from that also illustrates to you the different levels of the attributes that I've previously just described. So the participants chose one of these scenarios over the other. So participants provided consent forms before they could proceed with the 20-minute web-based DC survey. Screening questions were used before the experimental choice tasks to confirm eligibility, including UK residency status, and to ensure that participants were aged 18 years and over. The study information explaining the purpose of the research, what participation would involve, the estimated time to complete the survey, and obtaining respondents' consent. The questionnaire survey instrument also included background information on climate change, including information on the causes and impacts of climate change, and information on the UK government and NHS's carbon emissions commitment. Respondents provided demographic and socioeconomic information, including highest level of education, employment status, and marital status. And there was also an introduction to the hypothetical choice content, definitions of all the attributes and relevant levels, and explanation of the choice tasks, followed by presentation of the choice tasks. In addition, there was an open-ended question asking for any further information on participants' thoughts on climate change. So here are the results. It's quite a busy slide. That information might not necessarily mean too much to you at the moment. But in essence, and I'll just pop on to the next slide because it will make more sense now. We use conditional logistic regression to analyse the data from the discrete choice experiment. So conditional logistic regression is a statistical method used in the analysis of match case control studies. It's an extension of standard logistic regression that accounts for matching or stratification used in the study design. So essentially, it compares the risk of an event between individuals with the same match group. It's commonly used in things like observational studies, especially in epidemiology, to investigate the association between an outcome and various risk factors. So 1 unit of trade-off is equal here to 1 year of life expectancy. And so for a 5% decrease, the marginal rate of substitution is 0.7502 in this example. And the results of the DCE. Our highlights here include saving endangered species, increase the utility the most. So this is equivalent to 1.6 years of extra life expectancy, while endangered species becoming extinct reduced utility the most. Reduced carbon emissions increased utility, and increased carbon emissions reduced utility. The environmental impact occurring within the UK was preferred compared to the outside the UK, so overseas. And higher UK life expectancy increased utility. So the results of the survey indicated that people were willing to lose 0.75 years of life expectancy for a 5% reduction in CO2 emissions. They were also willing to lose 1.5 years of life expectancy to save 100 species from becoming extinct. And the results vary depending on the location of the environmental impact, for example, either in the UK or overseas. So the implications, some trade-off of healthcare for environmental gains may be accepted by the public. This was one of the key highlights for paper, and this can be estimated quantitatively. So what this information, this concept paper has shown is that perhaps this willingness to pay, this quantitative analysis might be able to contribute towards methodological development of an integrated analysis to be useful for evaluating environmental sustainability in health economics in HTA. The second implication is that policies focusing only on carbon emissions are likely to undervalue the public's preferences for the environment. So just coming back to planetary health and the importance of looking at those 9 boundaries holistically, so the broader environmental implications, not just CO2, but also the effects on water, fresh water, the effects on soil, the effects on air, all need to be considered, the broader implications of healthcare decision making, and that incorporating a broad set of environmental outcomes into HTA is therefore very important. The trade-off between broadening the scope of the environmental impacts considered in HTA is important, and the increased complexity and costs needed to measure them is also a critical point. So there are limitations to the study. The final sample may not be representative of the general population. Attributes and levels were developed using a pragmatic literature search and knowledge of the research team. The impact of environmental harm on human health was not included in the survey. The median response time was shorter than expected. And finally, the study was designed as an exploratory pilot. So whilst the study has shown that preferences for trade-off can be quantified, it is not suggested that the values presented in the paper be used to inform policies at this point. Given the limitations of the study, further research is required to gain a robust estimate of the true preferences for such trade-offs. So in conclusion, as climate change continues to grow and worsen, and evidence is growing as well, showing the negative environmental impact of healthcare, understanding public preferences in terms of the trade-off between human health and environmental outcomes is important. The study's results indicate that such trade-offs are tolerable to the public. It also suggests that environmental policies that solely focus on carbon emissions are likely to undervalue the public's preferences for the environment and may be less successful longer term than the inclusion of more holistic environmental outcomes. That's the end of the presentation. Thank you for listening. I'll pass back over to Sarin.
Thank you, Melissa and Matthew, for a wonderful and very informative presentation. Really exciting, and congratulations for getting this published, Mel and Matt. So as you may know, the participants had sent us a few questions during their registration. So maybe we'll start with some of them, and then we'll look at some of the questions that are on the live chat, some of which Matthew is already starting to address. So thank you for that. So the first question maybe would like to ask is, how do you make sure people understood and engage with the choices in your experiment?
Thanks, Sarah. That's a great question. Matt, do you want to, or do you want me to start? And we'll probably
I can cover that. So, I mean, we did lots of different steps to that. The first step was we tried the questionnaire out on colleagues in the office, first of all. So we just gave it to some of our friends and colleagues and said, can you try to answer these questions and let us know if you don't understand what you're doing? And we then asked them, did you follow that? In some cases, they said, yeah, it was mostly okay, but I didn't know what you meant by this, and we'd change it. We then did a more formal pilot study with not many, I think 35 respondents, I think there were in that one. And again, we asked them for feedback on the questions and whether they needed more context, more information. Based on that, we then changed the questions. They were mostly okay with it. It was only small changes by that point. So I think after that stage, we were quite comfortable. People did understand it. In reality, of course, we don't know for sure that they understand the hypothetical nature of the questions and whether that would reflect what they would do in the real world, but that's a limitation of all questionnaires.
Great, thank you, Matthew. Yeah, doing a pilot is always a good practice, right? And we should always do that in any survey-related studies. What I really liked about your paper was that you did this focus group discussion as a pilot. And not only that, you actually reported in the paper what changes you made to the survey questionnaire from the initial list of questionnaire, and also gave justification. So I think you don't see that type of detail in other papers. So it was really good to see, and something that maybe other studies should also start doing. Just to follow up on your response, Matthew, like you said, in reality, it's really difficult to say whether people actually understood the purpose of the question and the implications of their responses, right? But is there any way to test the validity of their responses?
One way you could test for validity of responses would be to include, I mentioned earlier, we wouldn't normally include questions that have obvious answers. So if each of the attributes was exactly the same, apart from one, which was better, you would expect 100% of people to choose that one. So if we included a question like that and some people still chose the opposite one, I guess that would maybe flag to us that people aren't reading the questions properly or aren't understanding them. You can't always rule out the fact maybe they just have strange preferences. Maybe in our questionnaire, we talked about life expectancy, we talked about species going extinct. Maybe some people want to die younger, or maybe some people want species to go extinct. That maybe they're answering genuinely in that way. It wouldn't mean that they're not reading the questions, but that would be one way to test for it. But you can never be absolutely sure why somebody answered a question.
Great. Thank you, Matt. Second question, very interesting one. How do you respond to people, often clinicians, who argue that there should be no trade-off here? Health should always win.
So that was, if I can answer that first, Mel, and then I'll pass over to you. That was the whole point of our questionnaire, really, because we do hear that a lot, and it's a valid view. If everybody in society agreed with that, then fine, then health wins. That's what we'd have to do. Huge caveat to that we'd only be asking people who are alive in society today. We're not asking people who are going to be on Earth in 100 years' time, because they might disagree with that approach, of course. But if everybody said health should always win and we're not prepared to make any trade-offs, fine, then we've got some information. We can use that in healthcare decision making. But we wanted to know, is that the case? Do people say that all the time, or are people actually willing to make trade-offs? So the whole point of our questionnaire was to find out if people say that, if they don't. It could have been that the results of our question was that there was zero trade-off with environmental outcomes. People always picked the option that had the better health outcomes. That would have been an interesting finding for us if we'd found that, but we didn't. We found that people are willing to make trade-offs. So if we answered clinicians who said that, we'd say, look at the results of our questionnaire. If you want to run your own questionnaire and do that, then absolutely do, and we'll see what results you get.
Yeah, and of course I completely agree with Matt. And DCEs are really interesting methods to find out, what people think, in terms of, and it to be able to quantify that is a really special method. So I'm putting my hat on as fellow for the British Medical Journal right now, which was my role before, and the Sustainable Quality Improvement Framework, where if you look at this from a holistic, out with health economics as such, so including health economics, say, because you need to look at financial costs, but looking at the triple bottom line, social, environmental, and financial implications. If we look at resource optimization, then there is the opportunity to save money at the same time as reducing carbon and improving patient outcomes and patient experience. So we can fulfill the sustainable quality improvement criteria if we look at resource optimization for the most part. So I think it's important to also think about, well, that's a wonderful question to ask, which is why I picked it, because it's very interesting to discuss trade-off. But what type of trade, if we think about how we can fulfill what we're looking to do, which is provide healthcare that's more sustainable to help towards universal health coverage, then one of the sustainable development goals, then we can look to optimize resource where we're reducing costs that will help to provide healthcare in other areas of the healthcare system. And then Matt and I would like to add, I know that he's in agreement with it, if we save money, then we need to know that what we're doing is that we're reinvesting that money in technologies and healthcare that's not going to be more environmentally harmful and more costly. So where you're actually saving that money by investing in more sustainable health technologies, we need to make sure that that's reinvested into more. He's smiling now because he's happy that reinvested into more sustainable health technologies.
Great. Thank you, Mel. Matt, I see you typing an answer, but maybe I'd like you to pause and actually respond. Oh, have you already answered that?
Which question did you mean? Sorry.
The question regarding balancing health and environmental priorities require integrated policy frameworks, right? But right now, these policies are made in silo. Is there any lessons on how they can be integrated?
It's so complicated. That's I agree with what Mel just said as well. There are so many different factors that come into this. On a practical level, no, I don't have any suggestions at all because I think it's just so hard to be able to do this. I could say on a theoretical, hypothetical level, absolutely. I think that there could be a centralized decision-making body that looks at these things globally. It includes all sectors in the equation and makes those decisions. I think there are lots of unanswered questions for me about whether it's the healthcare sector's responsibility to do this, whether it should be a level maybe above the health sector, maybe even a level above national boundaries and so on that does this. But of course, we get into very, very complicated territory at that stage.
Indeed. Another question, in your view, could these results also transfer to other health attributes? For example, would quality of life show similar results to life expectancy?
Yeah, so we'd have to speculate on that one, I think. We did want to include that, but we thought it would be too complicated trying to explain quality of life in the questionnaire, and we know from other examples that people interpret quality of life in different ways. We'd have had to find a very simplistic way of describing quality of life, and in the end we decided that life expectancy was just much cleaner and easier to include in that. I guess if a QALY is a QALY is a QALY rules are true, if quality adjusted life years always apply the same, whether they're length of life or quality of life, then yes, these findings should transfer almost directly into other metrics like quality of life. I'm not sure that is true. I'm not sure the respondents of the questionnaire would necessarily agree with that either. So we'd speculate, and if I'm allowed to speculate, I suspect that yes, they would transfer across. I think people would be prepared to trade off some quality of life. If they're prepared to trade off length of life, then perhaps they're prepared to trade off quality of life. The main difference for me is in a hypothetical questionnaire, at least, when people are trading off length of life, that's a long way in the future. A lot of people answering these questionnaires maybe think, oh, that's half a century away for me. I don't need to worry about that now. Whereas if we said your quality of life will fall today immediately, that might be a more stark contrast. It would certainly be an interesting way of asking the question to see if we get different results.
Yeah, thank you, Matt. In your paper, your time frame was 7 years, right? And one of the reasons that you've given is so that people can actually feel the impact in the near term rather than out in the distant. And I wonder if that time scale had been like you said, 50 years, 100 years, whether the trade-off would significantly drop.
That was exactly what we discussed when we designed the questionnaire. I think we went round in circles for quite a few weeks trying to decide on that exact time scale. I don't think 7 years is necessarily a definitive right answer for that. It would be really interesting to see different studies try different timescales and see if the strength of preference changes.
Indeed. So I'll go back to the questions that were shared during registration. How do policymakers view the findings, and how can they use the results into practical decision making, especially during reimbursement decisions?
So can I answer first? Mel, you might want to add something afterwards. First of all, I would say that they shouldn't use the results of our questionnaire at all. It's a pilot study. We were doing this to see whether it's feasible to do this. We weren't in no way trying to say these results should be used for policy making. It's pleasing for us to see that it looks like it is feasible. People did give what seemed to be sensible answers. I don't think it's exactly the right design. There are lots of things we'd probably change, which we can talk about later on. But if somebody then went on and did a bigger study, a better study with more kind of detail, maybe less hypothetical outcomes in there, then absolutely, I think that this would be really useful for policy making, because it would tell us not only that people are willing to trade, but it would tell us exactly how much people are willing to trade. So we'd be able to actually put a quantification on that trade-off between, for example, carbon emissions and quality adjusted life years or health output. So if we believed the results of a study like this, assuming it was conducted well and we all agreed with the design of it, then it would be able to be fed straight into a health technology assessment as a modifier to the either to the cost side or the quality side of the equation.
Of course, I agree with Matt on that. And so, hypothetically speaking, you know, obviously this is a concept paper as Matt's just described. But if you were to utilise the approaches outlined by Toolan et al., and one of those is the integrated analysis, and then this is perhaps a way to, well, of course, it's a feasibility study. You know, we're looking at whether we can quantify environmental impact and perhaps look to include it within the ISA. So going, you know, further down the line, if we were to go down that route of an integrated analysis, so attribute the quantification of environmental impact to the cost side. It's either the cost or outcome side. It seems to be a bit of a Marmite sort of discussion at the moment. You either are on the cost side or the outcome side. I'm sort of on both. Yeah. Right. But it's interesting, and that certainly maybe, and perhaps further DCEs might want to look more specifically at choices to do with intrinsic characteristics of health technologies. So, you know, single-use devices versus reusable, or different types of interventions, whether it's in the prevention space, if it's diagnostics. So that would be an interesting study to do next.
Indeed, Mel, agree. And thanks, Matt. So another question, which has received quite a few votes. How do you assess uncertainty in trade-offs? For example, how can we ensure that the trade-offs remain consistent across different types of health issues, care approaches, or environmental concerns?
I mean, quantitatively, that's straightforward. The trade-offs can generate confidence intervals around them, so we can see exactly what the coefficients look like. For the trade-offs, you just divide one coefficient by another, so you can still see the uncertainty around that product as well. So we can easily quantify that. Usually, as you increase the sample size, that might fall. But as we've said earlier on, things like different subpopulations might have different results and so on. So sometimes the variation that we see in responses isn't just random noise. It's actually because there are different groups of the population that have different opinions on these things. So all of that would be factored into the uncertainty here, just like it would in any statistical study.
Right.
Just to briefly add to that. So the baseline demographics, the characteristics were reasonably balanced in the sample population of 508 people. So that was, you know, to ascertain the results. Well, make this results more certain. But certainly going forward, as Matt said, increasing that sample size will increase the power and the statistical power if there's more balance between the demographics of each of the samples.
Perfect. Thank you both. Another question. In the methods, the author have given two options, right? The choice sets option A or option B. What if the participants are not able to decide between two options?
That's a great question.
Can you remember what we included? There are different approaches. I know in general in discrete choice experiments that you can offer a indifferent option. You can say, I can't decide. Some studies force people to make a decision each time. Some studies do allow that decision to say, I can't decide on that one. I can't remember what we included in this study. Do you happen to know, Mel?
Oh, that off the top of my head.
I can have a look.
Can we come back to you on that one, Saren, please?
Yeah.
Thank you.
Okay. Another heavy one. While health problems have external impacts, they may not be as far-reaching or comparable to those of environmental issues. Since DCEs rely on individual judgments, they may underestimate these externalities. How can we address this limitation in DCEs to better capture broader societal impacts?
It's a great question. So the cheat talk script, so the method used in stated preference studies, particularly choice experiments to reduce hypothetical bias, is really important. So providing and it's about getting the balance right, isn't it? So providing enough information, but not so much that they're not going to read it. So that background information provided to participants is really important. So describing each attribute in enough detail to make it understandable to what you might experience if you're in the UK, for example, or overseas. So that will help support and overcome that issue.
It will help. I think it'll help, Mel. But as you know, we don't even know what all the implications are. There might be implications to the environment that we've never even thought of yet. We as a species have never even thought of yet. So it's absolutely right that everything we include in this questionnaire is probably an underestimate of the real impact. And I think the only thing we can realistically do is conclude at the end to say that this most likely underestimates the true impacts. When we've described impacts, we've almost certainly underestimated it because I don't think we can do anything other than that.
No, I think the biggest argument about not doing a DCE for public preferences with regard to evaluating preferences which include environmental impacts is that really it's just so complex that the planetary boundaries diagram that on my first slide illustrates that, in just the complexity of how they all interact. To understand that, I think would take a lifetime. So it's a real challenge when you include public preferences in terms of of different environmental outcomes.
Indeed. I'm also learning that in a very difficult way, Mel, that this is a very complex area, and carbon emission is probably the simplest. It's already difficult, but it's the simplest way to capture, and it's always going to undervalue these externalities for sure. One last question, maybe to both of you. Given what's going on in the US, do you think has that affected UK's viewpoints, the progress and commitment towards environmental sustainability in any way? We are aware that both NICE and NHS formerly have been pioneering environmental sustainability in healthcare. So does it affect you at all?
In the short term, no. I guess it depends on whether there's a change of government in the next few years. If a future government might take a similar approach to the one you've just described, where things get changed at the top level. So we don't know at the moment. In the short term, no. In the short term, everything is exactly as it was.
Right. Let's hope it stays that way, because many countries are looking up to the UK in this space. So with that, I'll do a quick summary of key takeaways. These are not specific to your studies, but these are supposed to be quite general takeaways. So I guess the first should be Mel's first point, that many planetary boundaries have already been crossed, and that is a very dangerous thing to do with several health consequences. Second, health and environment objectives often go hand in hand, but not always. And in that case, discrete choice experiment can help us find these trade-offs. When you do design discrete choice experiments, you must choose appropriate attributes and their levels, and often in consultation with stakeholders and experts is advisable. Third, I know we didn't mention this in this webinar, but it's mentioned in the paper. We can share the link after the study. The The studies should ideally control for observed and unobserved heterogeneity in the sample in order to reduce any bias. And last, as mentioned before, carbon emissions alone is likely going to undervalue public preference for environmental protection. So with that, we would like to thank both Melissa and Matthew for your time, for sharing this interesting study and sharing knowledge. Thank you so much.
Thank you very much, Saren. Thank you, everyone. Take care.
Thank you. Bye-bye.
Thank you. Bye.